Welcome to today's webinar on pain management, and I'm so excited to introduce Shay Lunt to you. In fact, Shay just got back from maternity leave with Haugen Consulting Group. She just came back yesterday, so I'm so excited to be working with her, and as you heard when we did our sound check, I'm just excited to hear her voice again. So Shay is a consultant for Haugen Consulting Group. She's got a wealth of experience in physician auditing, billing, coding, and compliance. Shay lives on a family farm in South Central Kansas, and she just welcomed her second baby girl, Clementine Rose. So we're so excited to have Shay with us today. So Shay, go ahead and kick us off.
All right, thanks so much, Kathy. I'm happy to be here, happy to be back. I'm talking about pain management today, so hopefully everybody's in the right
Oops,
session.
Shay, I'm not hearing anything.
Oh no.
Oops, did we lose Shay? Let me see.
Hello? Oh, Dotsie says she hears me.
Okay, maybe you guys can hear her and I cannot, it sounds like. I will check my
Oh, and somebody else says they hear
sound.
me
Is
as
that correct?
well.
Okay, perfect. I had a couple of you were able to hear Shay, so I have lost it at this point. So I will work on it at my end, and Shay, you go ahead.
Okay, Kathy, that sounds good. Yeah, let us know if you are not able to hear me, but otherwise I'll keep going. So we're talking about pain management today. And what we're going to do is kind of the more popular outpatient treatments. Some of these you will see on the inpatient side as well, but trigger point coding, trigger point injection coding, epidural, so those codes were kind of rehauled in the last couple years. And then we'll go over some of the key terms and kind of ways you can get to the correct codes for those types of procedures. So we'll start with trigger point injections. You'll see that abbreviated a lot as TPI, but what they're used for is just to treat painful areas of muscle that contain trigger points. And what trigger points are just knots of muscles that form when the muscles don't relax. So they hurt if they're pressed on, they can be very tender, and they can really cause some intolerable pain. So the trigger points can actually irritate the nerves around them, and that's what caused the pain. And it can even be felt in different areas of the body where not even where those muscles are at, but commonly in the neck and the back. The trigger point injections involve an injection through a small needle, and it's usually of a local anesthetic or saline, some dextrose, and it could include corticosteroids, so like cortisone, into the trigger point, and that inactivates the trigger point and really helps with the pain. So there's a picture there. And here's the codes as well. So 20552 and 20553. And notice that it's going to be important to note that it's by muscle or muscles instead of by the actual number of injections that they do. These next few slides, we really wanted to give you some references on the different muscle groups. So that's what these next few slides are due. So remember, when you're coding for trigger point injections, you'll have to count the number of muscle groups that are injected, and that's going to select your CPT code. So it's not the number of injections itself. So, so these are the head and neck. And again, head and neck is a common area that these are done in. And then next we have upper back. So these are some of the common muscles again for trigger point injections. And these slides you can keep as a reference, and these will be great. Some of your CPT books will have references like this as well, but not all of them do. And then here's shoulder and upper back. And then we have chest, abdomen and pelvis, back and buttock, arms and hand, thigh and knee, And then last we have calf and foot. So kind of going from head to toe all the way down the body in those muscles that you'll see trigger points injections done. So just remember, not based on the number of injections, but on the number of muscles treated. So that brings us to this discussion on Modifier 50. This is kind of a common error that we see with clients, or a common question we have when doing audits. Trigger point injections, again, I've been saying this over and over, but they're coded based on the number of muscles treated. So they're not based on whether it's left or right or bilateral. So Modifier 50 is not going to be applicable to trigger point injection coding. And the next topic that kind of goes along with trigger point injection is dry needling. Dry needling is becoming kind of a popular way for to do pain management. And what this involves is an acupuncture needle that's being inserted into a trigger point, and then they rotate it and position it for therapeutic purposes. So it's a little bit like acupuncture and trigger point injections kind of combined into one modality. Unfortunately, there's not a CPT code for it. And since they're not injecting anything, it's not really a trigger point injection, and that's why it's called dry as well. There is a CPT assistant that we've listed here that says to report these with the unlisted procedure code 20999. If you're working with the physical therapy department, they might have a different opinion on that, but depending on what they're doing, I've seen where if they're doing some manual therapy along with the dry needling, they will include it in that manual therapy code, the 97140. And then there's also an unlisted physical therapy code that can be used for those physical therapists as well. So this brings us right into pop quiz number 1. So hopefully Kathy can hear me now.
I can, Shay.
Okay, good. And we can do the pop quiz. Okay, great.
Yes, no problem. I had my other speaker muted. So let me launch our first polling question. And we had to abbreviate this quite a bit, so I will read it to you. The physician performed 2 trigger point injections using Kenalog into the and hopefully I'm saying this right, supraspinal muscle, and 2 injections into the paraspinal muscle. What is the correct CPT code? Is it 20552 injections, single or multiple trigger point 1, comma 1 or 2 muscles, or is it code 20553 injections, single or multiple trigger points, 3 or more muscles? So you guys are quick. I just looked over to the polling. We've got over 50%. Ooh, we're up to 2/3. So what do you think? Is it code 20552 or 20553? Wonderful response. I am going to close the poll in 3, 2, 1. Okay, Shay, we've got an overwhelming majority at 93% is saying it is code 20552, but we have just a small minority is saying, nope, it's 20553.
Yeah, so it is actually 20552, so great job, everybody. There's 4 injections that were done, but there's only 2 muscle groups injected. So the 2 muscle groups were the supraspinal and the paraspinal. So 20552 is correct. Thank you, everybody. So the next topic that we have here is injection for SI joint. So the sacroiliac or the SI joint injection, it can be diagnostic or therapeutic. It's performed the same way for either diagnostic or therapeutic procedures. It's used to diagnose or treat low back pain or sciatica. So there's 2 SI joints, one on each side of the spine. They just lie right next to the spine. You can see in the picture, and they connect the sacrum with the iliac bone on both sides. So what happens is the injection is performed under fluoroscopy, which is like a live x-ray guidance, and that helps with accuracy. The needle goes into the SI joint. Contrast can be injected into the joint to ensure that the needle is in the right space and that the medication is being spread. There's numbing medication that can be injected into the joint, and then once that numbing medication is injected, the provider usually will ask the patient to perform movements to see if that pain is going to be relieved or not. So that's kind of what that SI joint injection looks like. There's only one code for that, and it is 27096. So you can see injection procedure for that SI joint. And that does include image guidance. So that can be fluoroscopy or CT. One note or one thing to note is if you're coding for an ambulatory surgical center, there's a separate code for Medicare patients, G0260, and that's just for if this procedure is done at an ASC. And there's the MLN Matters article. We put the reference on there in case you guys need it. So a few guidelines for the SI joint coding. Like I mentioned before, it's the same technique. Therapeutic is the same technique as diagnostic SI joints, except for usually there's a steroid that's included in the injection if it's going to be a therapeutic injection. So the guidelines are pretty straightforward, but 27096 is to be used only if there's CT or fluoroscopic guidance. If it's not being performed with CT or fluoroscopic guidance, you're going to use 20552. And it is a unilateral procedure, and since we have two SI joints, you can use Modifier 50 if they're doing it as a bilateral procedure during the same session. So hopefully that all makes sense. The next injection we're going to talk about is an epidural injection. So I mentioned this at the beginning, but these codes kind of changed within the last few years. But this is just a common treatment for many forms of low back pain or sciatica, leg pain. And the benefits really are just temporary relief from pain. It can be used during an acute episode of pain to provide sufficient relief, such as to allow a patient to progress with a rehab, stretching, or an exercise program. If the initial injection is effective, the patient may have more injections. I've seen a lot of patients get maybe 3 in a 1-year period of time. And then in addition to the low back pain or the lumbar region, they can also be used in the neck and the mid-spine thoracic region as well. So here's the codes, and there's your picture of the spine. So whenever I see this picture, I always have like flashbacks to college and having to learn anatomy and remembering that the cervical has 7 vertebrae, thoracic has 12, lumbar has 5 because you eat breakfast at 7, lunch at 12, and dinner at 5. So I don't know if anybody else learned it that way, but that automatically always pops in my head. But these codes are divided by the anatomy. So you can see cervical or thoracic is right here. And then once we get down to the 62322, that goes down to the lumbar or sacral region. So the differences are going to be the region of the spine, and then we'll have without image guidance first, and then with image guidance, then we move down to lumbar or sacral, without image guidance, and then with image guidance. So pretty straightforward. We also have codes for prolonged epidural injections. So these are for an indwelling catheter placement, and they are divided the same way. So you'll see the cervical or thoracic first without image guidance, and then it moves down to with image guidance. We get down to 62326. We are in the lumbar or sacral region without image guidance, and then moving to with image guidance. There is an MUE of 1, so only one unit of 62320 through 62327 should be billed per spinal region, no matter how many injections are made in that region. And then this screen really just gives us the steps for coding epidural injection. So first we're going to need to know, was it an injection or is it an indwelling catheter that's going to be in place for more than one calendar day? And then the location, so is it going to be cervical or thoracic, or is it going to be in the lumbar or sacral region? And then the third step is just going to be able to tell, for you to be able to tell whether the service was performed with image guidance or without. And we actually have just a summary slide of these codes as well. So you can see this chart just kind of breaks it down. If it's an injection, with or without image guidance, and then is it cervical, thoracic, or lumbar or sacral? And then same with the prolonged indwelling catheters, with or without image guidance, and then the region of the spine there. So that can be pretty handy if you need a quick reference for those codes. And moving on from epidural injections, we're going to talk about nerve blocks next. Nerve blocks are used for pain treatment management. They're reported according to the nerve or the plexus targeted. And when we say plexus, a plexus is just going to be a branching network of vessels or nerves that could be blood vessels or lymphatic vessels. And then nerves are generally axons outside of the central nervous system. So you can kind of see that illustrated in that picture here. For coding for nerve blocks, you're going to need to know what type of substance was injected. So is it an anesthetic? And some of those examples are Novocaine, Xylocaine, Marcaine. And you can always Google if you're not sure. But those are some of the common ones. If it is an anesthetic, you're going to go to code 64400 through 64530. Or it could be a neurolytic substance. And a neurolytic substance is used to destroy the nerve. So that could be like phenol or ethyl alcohol. Those codes are going to be 64600 through 64681. And then you're going to have to differentiate the nerves by name and then differentiate between a single level or multiple level. So here's an example of those codes. And then that picture just kind of gives you the zones that the nerves, this is the trigeminal nerve controls. So you can see the nerves by name, and then these are for anesthetic agent, and this is for the trigeminal nerve. So you can see all the different codes we have there. So important that your documentation is there so you can choose the right codes. And then on the next slide, I just kind of put the cranial nerves here for a reference, but you can see the different cranial nerves and what they do. I remember having to memorize these also at some point in college, and we had a mnemonic, and some of you guys might have heard this or maybe have heard of a different mnemonic, but ours was on occasion our trusty truck acts funny, very good vehicle anyhow. So that was how we remembered the names of the nerves, and then whether if it was sensory, motor, or both, we would say, some say marry money, but my brother says big brains matter more. So those were just kind of funny things that came to my mind as I was looking at these again. And here's a picture of your cranial nerves where they are at. And then moving on from the cranial nerves, we're going to talk about transforaminal epidural next. This injection is in the administration of a long-acting steroid into the intravertebral foramen. So that's located on each side of the vertebrae, and it's where the nerve root exits the spinal column. So that's where the physician or provider is going to inject an anesthetic, or it could be a steroid, into the epidural space using that transforaminal approach, doing that with fluoroscopy or CT. It's generally used for patients that have herniated discs, and the injection can be performed at one or more levels. And when we say levels, it refers to the intervertebral joint. So the example I have on the slide is L2, L3. That's the joint space, not each individual nerve. So some of the terminology gets a little confusing, but if you try to think back to your anatomy, it does kind of make sense. Here you can see all the anatomy I just mentioned. So the spinal cord, the vertebral body, and then you can see the facet joints with the neuroforamen right there. So this brings us to pop quiz number 2.
Okay, I just launched it, so here's what we want to know. The physician provides diagnostic transformational epidural bilateral nerve blocks with CT guidance for C2, C3, and C4. What is the correct CPT code or codes? Is it 64479? Is it 64480? Or is it 64479 and 64480? So I see responses are a little slower, not quite as sure as they were on the first one. So what do you think this one is? The physician provides diagnostic transformational epidural bilateral nerve blocks with CT guidance for C2, C3, and C4. What is the correct CPT code or codes? And we've got some more responses coming in. Looks like we're going to have a little bit of discussion there, Shay. So this is just a great time for you to kind of interact with us as we do these webinars. And then to me, it always brings about some good discussion. So it's not like anybody's really tracking who got them right or wrong. It's just a good way to interact with us. So I'm going to get ready to close the poll. 3, 2, 1. Okay, Shay, we've got 94%. So pretty much the overwhelming majority is saying it's 64479 and 64480. But we do have just a couple of people who are saying, I think it's 64479.
Okay, great job, guys. It is 64479, and then we have the add-on code of 64480. So C is correct. C2 to C3 is going to be our first level, and then C3 to C4 is an additional level. So that's how we get the 64479 with the add-on code 64480. So good job. And the next topic we have is paravertebral facet joint injections. So just as the intervertebral foramen that we just discussed, the facet joint levels refer to the joints that are blocked and not the number of nerve branches that innervate them. Those paravertebral facet joints, they're also called zygapophyseal or Z joints. So you'll see that when we get to the code descriptions. But the facet joints are the joints in the spine that allow the back to be flexible and also allow our bodies to bend and twist. Nerves exit the spinal cord through these joints on their way to the other parts of the body. So we have our codes next. We have the codes listed here. So CPT code 64490 and 64493. These are intended to report all the nerves that innervate the first paravertebral facet joint level that is injected, and not each nerve. CPT code 64491, 92, 9495, those add-on codes you see there, they're used to report each additional paravertebral facet joint level, and again, not each additional nerve. And when we say innervate, that just means to put the nerve into something. So when nerves go into a muscle fiber, when nerves go into a muscle fiber, they innervate that muscle fiber. So innervate is to supply nerves to something, but it can also mean to energize. So if you think of all the energy you have when you get nervous, sometimes nervousness can even innervate the hairs on your arms. In other words, overstimulate them and make them stand up. So that's just kind of a fun fact when we think about these types of injections. And we have a picture next to kind of illustrate that. But there you see the needle going into that facet joint space and the nerve coming out of this off the spinal cord. So we talked a little bit about neurolytic agents, but they are going to be any agent that's destroying nerve tissue. So a neurolytic block is a form of nerve block that involves deliberate injury of a nerve by the application of chemicals. And the purpose is really just to provide that ongoing pain relief that could be from disease or an abnormality of that nerve root. The procedures are sometimes called rhizotomy, and they provide pain at different time intervals, but it could be weeks for up to a year. Some of the methods can be chemical, thermal, electro, radio frequency method. They are usually used to treat chronic pain, so such as chronic back pain. And what happens is the affected cervical or thoracic spinal nerve is actually destroyed either using chemical, thermal, electro, or radio frequency techniques. And those can be used independently of themselves or used in combination. And again, they're just destroying the specific sites in the nerve that produce the pain, but they leave the sensation intact. So some of the neurolytic substance examples, and I've already gave some of them, but phenyl, alcohol, glycerol, and Botox are commonly used. So here's some of the common codes. So these are kind of broken up by location. You'll see our first one is for intercostal nerves, and then we go into the paravertebral facet joint nerves. And this is with image guidance, and the first one's going to be for thoracic or cervical. That's going to be the single facet joint, and then we have the add-on code for each additional. And then 64635 is that same code, but it's for lumbar or sacral. This is going to be the single, and then if we have each additional facet joints for the lumbar or sacral there. There are some CPT guidelines that go along with these codes. So that's what we have next. Image guidance, either fluoroscopy or CT, and any injection of contrast, those are included in 64633 through 64636. Image guidance and localization is required for paravertebral facet joint nerve destruction by neurolytic agents. If the CT or fluoroscopic imaging is not used, you have to go to an unlisted code, so 64999. If it's bilateral, you can report with Modifier 50. So again, these are just guidelines that CPT gives us for these procedures. And just a couple more. These are considered unilateral, so they should be reported once per level per side. If there's multiple injections at the same level on the same side, that's all going to be included in one code. So in summary, for those injections that are used to treat pain, we are going to need to know the approach. So is it an epidural, transforaminal, or facet injection? What's being injected? Is it an anesthetic, a steroid, contrast, or a neurolytic agent? What regions are being treated? So is it cervical, thoracic, lumbar, sacral? How many levels are being treated? And laterality to apply that if it's appropriate. So those are just some things to think about when you're reading documentation or when you're trying to improve documentation to make sure and get that all included so we can choose the specific codes. The next topic that we have is chemodenervation of muscles. Chemodenervation is a minimally invasive pain management procedure, and it's used to eliminate or reduce pain from a variety of neurological disorders. What it does is it paralyzes a group of muscles with the toxin called Botox. It's C botulinum. It's one of the most poisonous substances, but it's really proven to be successful therapeutically in extremely small doses. And usually, once it's injected, the muscles do become temporarily paralyzed within 24 to 48 hours. And this really helps decrease chronic pain from muscle spasms or stiff muscles. And that duration of the effect really varies between people, but a common interval is noted to be 3 or 4 months. So 64612 is the first code that we have listed here. Commonly, it's used for blepharospasm, and this is a condition that causes uncontrollable eyelid muscle contractions. And then 64615 is used a lot for chronic migraines. This is quite a lot of injections. It usually includes 30 or more injection sites over 7 muscle groups, and they're typically on the face, head, neck, and upper back. You can report ultrasound guidance, so 76942 with these codes. And if you get into chemodenervation of the neck muscles, those are down in 64616 and 64617. Here is some codes for chemodenervation of extremities of trunk muscles. So these are reported once per extremity. You report only one base code per session, so 64642 or 64644, and then 1 unit of additional extremity codes for each additional extremity injected. So those are the add-on codes. For the chemodenervation guidelines, CPT does give us a few rules to follow. If it's chemodenervation guided by needle, EMG, or muscle electrical stimulation, there's some add-on codes for that. So 95873, 95874. Do not report more than 1 guidance code for each corresponding chemodenervation of extremity or trunk codes, and then do not report modifier 50 with these codes as well. Here are the codes for electrical stimulation for guidance in conjunction with chemotherapy, or chemodenervation 95873, and then there's the needle EMG 95874. And again, do not report more than 1 guidance code for each corresponding chemodenervation code. This is a frequently asked question. We've seen this also in a lot of audits, and we get this question too. If chemodenervation is performed on 4 extremities, which it definitely is sometimes, so you would report 64642, 434445. Can 4 units of 95874 be reported? Yes, it can, and this was answered in the CPT assistant, and you can see our reference there. The parenthetical indicates that needle EMG can be appropriately reported together up to a combined total of 4 units of service when all 4 extremities are injected. So technically, yes, it can be reported that way. So we have a few coding examples to go over, and we'll just kind of take some time to go over these together. But this is a patient that comes in with MS, has spasms in both legs and the left upper arm. The provider injects the following limbs and muscles with Botox without EMG guidance. So I'll give everybody a few minutes to look at this. And we do have the codes referenced back a few slides. I believe it's slide 42 that you can look back if you have the slide deck. So we're looking at both legs and then one arm, and quite a few muscles were injected with Botox. These are the codes that we're looking at. So if you're looking for the codes, And then let's just take a look at what we have. For the right lower limb, we're going to do the 6-4-6-4-2. That's going to be our first extremity. Up to 4 muscles were injected. So you can see 3 muscles there. And then for the left, we have, again, 3 muscles were injected. We'll do the add-on code since it's a different extremity or an additional extremity. 6-4-6-4-3. And then we'll do 6-4-6-4-3 again for that left upper limb. Biceps, and you can see all of the muscles injected there. And we have another example. So again, I'll give you guys a few minutes to take a look at this. And this one is a patient that has MS that's presenting again with spasms in both the left and right upper arms. Provider injects the following limbs and muscles with Botox with EMG guidance. And these are the codes that we're looking at. So again, this was a patient that presented with spasms in both the left and right upper arms. The provider did injections in the left upper arm. And it does look like we have a little bit of a mistake here. That he did do right and left upper arms. So we have left listed twice, but you can see on our coding here, we meant right on that second example there. So left upper arm, 6-4-6-4-4, and this was 5 or more muscles, and then 6-4-6-4-3, and then we have our add-on code of EMG guidance, so 95874 for both of those extremities. And this is our final pop quiz.
Okay, on your screen, here's our question. Chemodenervation codes 64642 to 64647 are coded by injections, muscles, or I'm confused and I don't know. So chemodenervation codes 64642 to 64647 are coded by injections, muscles, or I'm confused and I don't know. So we got responses coming in. Looks like we're going to have some great discussions on this one, Shay. We've kind of got answers all over the place, so we might need to spend a couple minutes on this one. So what do you think? They're coded by injections, muscles, or you don't have a clue and you are confused? So anybody else want to weigh in? I'm going to close the poll in 3, 2, 1. Okay, Shay, we've got answers all over the board, although we have the majority. 88% is saying the answer is they are coded by muscles. And then we've got it tied as a minority, but you know, a little less. We've got 6% is saying it's injections, and we have 6% of our audience is saying they are confused.
Okay, great, Kathy. I put the slide on here so we can see the actual codes we're talking about. But 64642 and 64647, they're broken up by how many muscles. So meaning that sometimes you'll see in notes where they injected the same muscle twice. So it's not really coded by how many injections, but really how many muscles. in the extremities. So that was correct, and the majority of you guys were correct with that answer. Okay, let me get back to where we are at. And that is the end of our presentation today. So I think we have maybe a couple questions, Kathy.
We sure do. So we've got, and I'm glad we've got some time for these. So the first question that came in is, would we count it as two muscles if the same muscle was injected bilaterally?
And this was what kind of injection?
It came in very early. I wasn't sure what slide it came in on. Let me see who typed that in. She just responded, trigger point.
Oh, okay. So that was at the very beginning.
Right. So would they count the trigger point as two, trigger point injection, would it count as two muscles if the same muscle was injected bilaterally?
Yeah, so as long as it's two different muscles, that would be, you're still going to be in the the 20552 code. So it's going to be the one or two muscles. So as long as it's two different muscles, you're going to still count the muscles separately. So hopefully that makes sense. Okay, good.
Perfect. Yes.
Yeah, it's really just going to be, yeah, it's just, sometimes they'll just do the exact same injection in the same muscle more than once, and that's when you can't count that again.
Perfect. Thank you, Catherine, for typing in, and thanks for the clarification. So we've got another one, Shay. Is there a frequency limit for trigger point injections?
So that's a really great question, and that comes up a lot. So, and I would actually caution you guys with all of these pain management procedures is to check your max. So for trigger point injections, there's not an NCD on them, but there are a lot of max that have LCDs. So depending on your MAC, it might limit you, or your payer. Even private payers have frequency limitations for trigger point. So in theory, the frequency really should be determined by the clinician, but some payers are putting limits on this. So one example I've seen is that and I can't recall exactly which MAC it is, but there's an LCD stating that there's no peer-reviewed literature to substantiate more than 4 trigger point injections in a year. So that's pretty low. But again, CMS doesn't have an NCD, so you'll want to check your MAC as well as your commercial payer policies for trigger point injections. They'll also include information like documentation requirements, or even if they need to document what treatment has failed, like if they're doing conservative management that has failed, what modalities have they tried or what techniques have they tried. Sometimes that needs to be met before they will cover trigger point injections, and things like that. So always check your max for LCDs for trigger point injections. If you're looking for LCDs, usually you can get them right off your max website by searching the CPT codes, or even like searching by the keywords trigger point, and those will come up. But it really varies between payers and max. So I highly recommend that, especially if you're getting denials and you're not sure why. Check for frequency limits for trigger point injections. And really, a lot of these procedures that we talked about today could have LCDs as well. So I know the LCDs can vary by MAC, but I have seen LCDs in a lot of these areas in pain management. So always check for that MAC guidance.
Okay, Shay, we had a couple more come in. Could you show and tell us, so I don't know if they want you to go back to the slide and tell us your mnemonic again? Apparently they
Oh,
liked your mnemonic.
for the what was it? It was for the cranial or for the
I think you had
spine,
two of them.
maybe. Okay, well, we'll just do them both real quick here since we have time. For the spine, if you're trying to remember how many vertebrae are in each region of the spine. So cervical has 7, thoracic has 12, lumbar has 5. You eat breakfast at 7, lunch at 12, and dinner at 5. So that was that one. And then for the, what was it? It was for this, I think. For the cranial nerves, if you're trying to remember those, a mnemonic was on occasion, our trusty truck acts funny. Very good vehicle, anyhow. And then if you're trying to remember whether it's sensory or motor, first you write out the name of your cranial nerves and then you can write next to it whether it's sensory, motor, or both. And remember that by saying, some say marry money, but my brother says big brains matter more. So
I thought that was cute.
I guess it worked because I remember it for like, I don't know, ever now. So I guess it works.
Oh, that's funny. That's great. Oh, thank you. We gotta thank you. Okay, and then the last one so far, unless anybody has any other questions, is can you go back to the pop quiz number 1, which I think was on slide 18? And they just wanted you to go over that response again. I think there's some confusion about the correct CPT code for this one.
Oh, okay. So the, and you guys can see that screen now, right?
Right, they can see your
Okay.
slide. We don't have
Okay,
to
perfect.
relaunch the poll. Yeah.
Perfect. Okay, so this one, there was 2 trigger point injections done, and they did the supraspinal muscle, and then 2 injections into the paraspinal muscle. So, and let me, so the answer is 20552. So even though there's multiple injections that they're doing here, so they did 2 in each of the muscles, you'll see that the codes specify 1 or 2 muscles. So they're not counting how many injections are being done, it's counting how many muscles are being injected. So the first muscle is the supraspinal, and then the second muscle is the paraspinal muscle. So we have 2 different muscles being injected. So that's why we're on the 20552 code.
Perfect, Shay. That answers that question. So thank you. Thank you so much. Okay, and now if you'll scroll to the very end.
Sure. Oh, there, right?
There you go. Yep, perfect.
Okay.
So thank you, everybody. And hey, for the first time, we're getting done a little early. So we want to thank everybody for your time and attention to today's handouts. Remember to download the handouts that are under the materials tab as well as the CEU certificates. But I did want to mention, if you enjoyed today's webinar and you enjoy our webinar series, upcoming on October 10th, we have breast cancer coding, and December 12th, for you prophy coders, we have the 2019 CPT updates. You can also mention too, if you're also a facility coder, next week already, we're going to be talking about the IPPS 2019 updates. We're going to be doing some respiratory coding, ICD-10 CM respiratory coding on October 18th. And then we're going to be coding in the cath lab coming up on November 15th. So thank you again. We had great questions. We had great discussions. Thank you for your time and attention. Please take a couple minutes, fill out the survey when you exit out of here, and then look for a follow-up email within 48 hours, which will have the recording link and all materials and CEUs as well. So thank you, Shay, for a wonderful presentation, and thank you everybody for joining us. Go and have a great rest of your afternoon. Thanks. Bye-bye.